presentation, and thank you for joining us.
Thank you.
Before we go to the last part of this webinar, which is a surprise, it's a live workshop from Canada presented by Professor Walid Qashta, Professor and Head of Orthopedic Department, McMaster University, about osteotomies around the hip. We will have a short presentation from the sponsoring company, Eva Pharma company. Dr. Michael will present the presentation. Dr. Michael, please.
Thank you, Professor. Is my screen is clear?
Yes, sir. Full screen, sir.
Thank you. Thank you, Professor Ashab. Actually, if I thank you a million times, I wouldn't give you your right. You're always keen on organizing such an innovative scientific events. And thank you for giving us a chance to present our products. Actually, in Eva Pharma, we have a variety of products, chondroprotective products, products for rheumatoid arthritis. But in this night, I will be presenting neuropathy and the pain domain products. This is a rehearsal from the last webinar, so I will be so fast in going through my slides. For your notice, our products are present not only in Egypt, but it's also present in other countries worldwide. So that will be my first slide. I would like to let you all know that in Eva Pharma, we have European Medicine Agency approval, and this approval we got since 2014. And up to 10 years, we get the European Medicine Agency approval, which is an inspection which comes from the European Federation, which inspects all our manufacturing techniques, our pharmaceutical manufacturing techniques, and our source of active ingredients, which makes us unique and allow us to export all our products to the European Union and other countries. So we always believe that no one size fits all, but every product from Eva Pharma is of high quality product. In my presentation, I will be going through the pathogenetic treatment in case of entrapment in neuropathies, and then symptomatic neuropathic pain treatments. And lastly, I will be going through the nociceptive treatments. Let's begin with our hero in the pathogenetic treatment, which is thiotacid, our alpha-lipoic acid, which is present in more than 40 countries worldwide. So actually, if you are present in one of these countries, you will find thiotacid by name, but in Canada, its name is diapathic. Actually, we are talking in these cases, sciatica, low back pain, trigeminal neuralgia, carpal tunnel syndrome, all kinds of entrapment in neuropathies. You have to give a pathogenetic treatment along with a symptomatic treatment. What is the pathogenesis of any entrapment in neuropathy? Actually, what happened is microvascular changes. Any entrapment like low back pain and sciatica will lead to low blood supply to the nerve, like sciatic nerve or the median nerve in case of carpal tunnel, and that will lead to nerve hypoxia, which will lead to inflammation and oxidative stress, the release of free radicals, which led to the activation of nuclear factor kappa beta, the transcription factor, which will increase the interleukins, the cytokines, and tumor necrosing factor, which will lead to inflammation and lastly pain. And that will lead to demyelination of the nerve, which actually makes the excessive firing from the nerve and led to the pain the patient experience and the drive to your clinic with. That's where it comes the role of thiotacid, our alpha-lipoic acid, which works as an antioxidant, which stops the process of the pathogenesis from the beginning. It also works as anti-inflammatory, which suppresses the inflammatory activity from interleukins, tumor necrosing factor, nuclear factor kappa beta. It also works as a neuroprotective by increasing the nerve growth factor, which allows the maintenance and remyelination of the deteriorated nerve. And it also works as a vasoprotective, which improves the nerve blood supply. Whatever you give a symptomatic treatment to this patient, whatever the kind of the neuropathic painkiller to give in the patients of entrapment in neuropathies, there will be no improvement without a pathogenetic treatment. That's why we recommend Cytosine in doses of 3 tablets per day in case of severe cases, 2 tablets per day in case of mild to moderate cases, and maintenance dose with a once daily tablet. Our other hero in case of entrapment in neuropathies is Melga Advance, which is a synergistic combination of pemphotiamine and vitamin B6, vitamin B12. The pemphotiamine here is the synthetic lipophilic form from vitamin B1. As you all know that vitamin B1 is hydrophilic, so the patient, it has a very poor absorption, poor bioavailability, and the patient will not get the maximum benefit from it. So the pemphotiamine is the lipophilic form of vitamin B1. Here is Melga Advance, which is an alternative for the injections from vitamin B1s. The WHO recommended only the injections from vitamins, from multivitamins, in case of patients who have inability to swallow, who have vomiting, in case of serious and life-threatening illness. So Melga Advance you can use in alternative to the injections from vitamin B1. And here is a study which carried out in the Diabetic Institute here in Egypt, which compares Melga Advance versus the vitamin B1 injections. And actually, the levels of vitamin B1 in the blood were higher after taking Melga Advance versus the other injections. And the results was carried out after 2.5 hours and after 6 days, and there was a significant difference between Melga Advance and the injections. Here is another hero in Eva Pharma, which is limitless vitamin B12, which is mainly a B12 vitamin B12 product plus folic acid, biotin, vitamin B1, vitamin B6, which is made in a new technology, which is an oral dispersible film. It's easy to use, and it works and dissolves within 15 seconds only. Let's move to the symptomatic neuropathic pain treatment. And you know all Conventin, our gabapentin in Eva Pharma, but here is the latest technique in gabapentin, which is gabapentin gastroretentive tablets. As you can see, when the tablet of Conventin XR or gabapentin XR enters the stomach, it swells to a size which allows it to retain in the stomach for up to 15 hours. It continues release of the gabapentin from 8 to 10 hours, and then the tablet dissolves within 15 hours. So you have to take it just once daily, and it covers 24 hours. And here is the pharmacokinetic curve, which reveals this process in details. Here is the blue curve represents the gabapentin IR or gabapentin immediate release. And in case of gabapentin immediate release, there are 3 peaks during the day, which were the main cause of the gabapentin side effects, sedation, abuse, any somnolence, any other side effect of gabapentin. But in case of gabapentin gastroretentive, here is the curve covering 24 hours, and there is only 1 peak, which is during the patient's sleep. So you will not find any side effect in case of gabapentin gastroretentive. Actually, this allows a better absorption, minimizes the saturation of the uptake of the gabapentin, and better tolerability for the patient. Our another hero is duloxetine. As I said in the beginning, we always believe that there is no one size fits all. We have Sympatex in a molecule called duloxetine, which works in another mechanism of action rather than gabapentin. But the main benefit of duloxetine is that it doesn't work only as a neuropathic painkiller, but it also works as antidepressant. And we all know that patients like chronic low back pain patients are suffering from sleep disturbance and anxiety. So Sympatex reduces not only pain, but also improves the sleep quality and improves the mood of the patient. Duloxetine or Sympatex is recognized by many international organizations like EFNS, NICE, Canadian Pain Society, as a first-line treatment for treatment of neuropathic pain in case of entrapment neuropathies. Actually, what makes Sympatex unique is that the molecule duloxetine is always subjected for phototransformation. So Sympatex is the only brand which is made by Alo technique, which prevents it from the phototransformation deterioration and protects it from moisture. Then we will move to our nociceptive pain products, which is the Stopadol range. I know that the paracetamol molecule. Stopadol here is in Egypt. Paracetamol 1000 milligram, which is Stopadol form in the form of effervescent tablet in orange taste. You can use it in case of acute cases in orthopedic management. And we have also Stopadol extended release, paracetamol 650 milligram for chronic cases, osteoarthritis, and other joints pain. In case of Stopadol extended release, it's made with a technology which allows its release on 2-pi layer, a fast releasing within 15 minutes, immediate release top layer, and a long-lasting or extended release bottom layer. So it have 2 layers of release. One of them is fast and the other is long-lasting. It's advised to be used in case of chronic cases. Our last brand in case of nociceptive pain is Lepradeclan, which is a diclofenac sodium patch, one medicated plaster, which is applied twice daily every 12 hours. Actually, what makes it unique is that the diclofenac sodium in form of patches or Lepradeclan absorption is 2 to 10 times the absorption of the oral diclofenac. So we actually have a negligible side effect because diclofenac doesn't reach the systemic circulation. It works only on the site of its action. Thank you, and I hope that I was concise. Thank you, Professor Asha.
Thank you so much, Dr. Michael. واحنا كده احنا يعني وصلنا لآخر حاجة the big surprise in the webinar. It's a live workshop transmitted live from Canada, from McMaster University, about osteotomies around the hip, and presented by Professor Walid Kashta, professor and head of orthopedic department, McMaster University. Professor Walid is joining now, and after Professor Walid will finish his workshop, we will again replay the workshop of Professor Gamal Hosni in the start because of some technical errors during making it live. So we will again replay it as a recorded workshop. And if anyone wants to see it, he will be ready after Professor Walid. Professor Walid is joining. Professor Walid, you are with us, sir? Has just finished his work because of the time difference with Canada. He's saying he's joining at once. Professor Walid is joining in just 1 minute. There is 7 hours time difference between Egypt and Canada.
السلام عليكم دكتور محمد.
عليكم السلام ورحمة الله وبركاته. دكتور وليد، ازي حضرتك يا فندم؟
الحمد لله تمام.
منور يا فندم معانا.
ده نور حضرتك.
ربنا يبارك في سيادتك يا فندم.
شكرا على الدعوة الجميلة، ومعذرة على التأخير. طول ما أنا قاعد
عفوا يا
مستني
فندم.
أفكر في حالات تيجي في بالي، عايز أضيفها عشان نتناقش فيها.
ربنا يبارك في حضرتك يا فندم، جزاكم الله كل خير يا فندم.
Um, I know this is a workshop, but let's start with the case and then we'll go with the case solving. So this patient is 18 months old, presented with left hip dysplasia. Patient is normal, so this is non-syndromic hip dislocation or not a neuromuscular hip dislocation. She's completely normal, healthy. She just had a history of breech presentation. She's the first child, and she's female, and there is no family history of DDH. I would like to see what you guys think in the comments. Just write to me what will be your decision for the treatment, and then we'll go through the treatment technique step by step afterwards.
You can write in the question and answer box, my dear friends.
Yeah.
What's the optimum way of management of such a case?
Yes.
Yeah, open reduction left hip.
Open reduction.
CT is required.
CT required. Acetabular osteotomy. Excellent. Close the reduction. Open reduction and stability test. Open reduction, capsulorrhaphy, pelvic osteotomy, femur osteotomy on need if needed. DIGA osteotomy if needed. Perfect. Open reduction plus acetabular plus or minus femur osteotomy. Open reduction plus pelvic osteotomy plus minus femur osteotomy. Open reduction plus minus femur osteotomy. Perfect. So this is most of the answers running towards open reduction, capsulorrhaphy, which I agree, plus pelvic osteotomy. There's a lot of controversy about adding pelvic osteotomy at this age versus not capsulorrhaphy, pelvic osteotomy. So that's very good. Thank you for all your answers. Some people say standard of care 18 months do pelvic osteotomy, open reduction pelvic osteotomy. And I go even beyond this. I do open reduction pelvic osteotomy even at the age of 12 months. This sounds too aggressive to some people, but in my practice, I found if I do everything in one attack, it's fine. Sometimes I see a patient young enough not to have enough bone to do the pelvic osteotomy. This is a patient I would wait, but if they have enough LM, then I feel free, because the only block for you to do pelvic osteotomy if needed is if you don't have enough bone stock. But if I have enough bone stock, the child is big, so I don't mind the age. And this way, I feel like I save them from another surgery in the future. There is a study done recently showing the percentage of cases that has done closed reduction versus just open reduction young age. They found 60% of them needed pelvic osteotomy for the age of 4. So I want to save this. But it's still controversial. And a lot of people just do open reduction, but 18 months, I would do open reduction, pelvic osteotomy, plus or minus femur shortening. And I agree if needed. From this X-ray, I feel like I don't need it because it's 2:2, but if it's very high dislocation, then shortening will be helpful for the reduction and decrease the tension on the femur head to avoid the AVN. I totally agree with this. So let's talk about the technique. So now my plan is open reduction. I'm ready for Dega osteotomy or pelvic osteotomy. I said Dega, but because it's my favorite, this is biased, but any osteotomy would be fine. If you want to do Salter, it's okay. If you want to do Pemberton, it's fine. If you want to do Dega, it's okay. So any of them is fine. So now, in your booking sheet, what do you want to ask for in this similar case? So please write your comments. What kind of plate? What kind of bed? Do you need a hip spica table? Do you want to use the arthrogram? Do you need C-arm? People work in the private. You think about which private hospital that has the equipment you need. Pediatric anesthesia. So what do you guys think? Or what do you use for femur shortening?
Yeah. Do you ask for CT?
Do you ask for CT scan to measure neck anteversion? Thanks, Dr. Ali, for this question. I don't, especially at this age. So number one, it's too much radiation for this age. And the question, is it really needed or not? It's not needed. Anteversion is common at this age in normal kids. So I don't consider this as important point to deal with. Even if I need to do femur shortening, I don't change the version. So I don't do derotation. So I avoid the word VDRO. I had von Rosen view, but because of the time, I just uploaded the X-ray. So I just uploaded the AP, but it didn't add anything. It's still dislocated with false acetabulum. Interoperative arthrogram, Dr. Ayman, it's a good point. Because I usually plan at this age for open reduction, pelvic osteotomy, I don't do arthrogram for them, but I do arthrogram for the cases with possible cross reduction. So usually at the age of 6 months to 1 year. So in my booking sheet, I asked for a flat top table, so I would be able to do X-ray with on the table, and I also ask for small fragment plate and screws in case if we do shortening. I asked for K-wires. I asked for the osteotomes, straight and curved osteotomes. What about the acetabular index? Yeah, so we know this is acetabular dysplasia, and we go with acetabular index to measure the acetabular dysplasia. And in this patient, the acetabular index was 35 degrees. I'm just trying to focus on surgical technique today more than the clinical case itself. We have done some discussions before about similar cases, but want to try to focus on the technical parts for surgery. So yeah, I asked for straight osteotome and curved osteotome, half-inch lamina spreader. I asked for Garrison, number 3, and periosteal elevators, K-wires, and small fragment plate and the C-arm. Any comments or before we go to the surgical technique? Vicryl nylon size 2 sutures, that's very good point. I use something called orthocord, which is kind of fiber wire, but it dissolves in about 3 to 6 months. But you can use Vicryl number 2. That's a very good option for the capsulorrhaphy. Excellent point. Perfect. So I took the child to OR. They usually have done pre-operative anesthesia. They see anesthesia 1 week before surgery. They go through all the vital system, and we discuss epidural versus caudal versus just general anesthesia. Do you use bone allograft for the Dega osteotomy? I don't use allograft for Dega osteotomy. I use the iliac bone itself. And we'll come to this point. What else? And I also booked the spica table because in our hospital we have to book the spica table. So this is a patient in the OR with a fluoro. Examined the hip before we start the opening, and I did examination under anesthesia. I found the hip is actually reducible when I asked the anesthetist to give paralysis to the patient or muscle relaxant, just avoid the word paralysis, but this is what we use here. And I found the adductor tendon is very tight, so I planned for adductor tenotomy. Do you guys do adductor tenotomy with open or with percutaneous with a needle? I just go down to the basement. We have some noise here, Dr. Mohammed.
Please, everybody's muted, please.
No, it's in my house. بس kids came back from the exams. امتحانات نص السنة.
بالتوفيق إن شاء الله دكتور وليد.
الله يخليك. I'm Muhammad and Henry. Yeah. No, it's okay. So open, use open adductor, percutaneous, open tenotomy, open adductor tenotomy. So there is a mixed answers. I found that percutaneous with a needle works with me recently. I used to do open, but sometimes you get complication with a small incision. If I get the same results, I'll do it with the needle. So I actually get the same results. I get the same abduction I need with the percutaneous. I get the 18 gauge small needle, and I make a small incision. And inside the small incision, just get the tip of the needle while the patient in abduction, and I start to scratch the tendon until I feel like I get enough abduction. And then I put steer strip, so you don't need to have a big incision with the hematoma and infection later on. I feel like I need the open adductor tenotomy for the CP kids because they need the adductor longus, brevis, sometimes the gracilis, so they need more. That's a good point, Dr. Emma. That's similar to the question. It's the Achilles tenotomy needed for the club feet. So it's mostly needed with the DDH because the adductor is tight. But again, examine the patient first, do as the patient need. If the patient doesn't have tight adductor, so you don't have to do it. Excellent. And next will be the patient positioning. What do you guys do for the positioning? Position and the drape. Supine was a pump under the gluteal region. Excellent. Supine. Perfect. So in supine, I bought just a folded green towel under the gluteal region and a little bit proximal, so wouldn't affect the gluteus. And also, I avoid the sandbag, to be honest, because sometimes it affects the X-ray radiation and the view. Perfect. And then draping, I use split sheets. So I bought a green towel. If we have a Foley catheter, which usually have a Foley catheter, get the Foley catheter. If the case is unilateral, I move the Foley catheter above the abdomen and more towards the right side. And when we prep, use a chlorhexidine for prep. I don't know it depends on your hospital, guys, but use a chlorhexidine except for the perineal areas and around the vagina or the penis, we use clear alcohol. Recently, we had a back order for the clear alcohol, so we use betadine. It's like the old technique because the chlorhexidine sometimes causes irritation and inflammation to the perineal area. Then we bought the sterile green towel at the middle to cover the Foley catheter and stuff. We bought the split sheet, and it's all different from hospital to hospital, but most of North America use the split sheet. Make sure you prep the whole femur and the pelvis as high as you can. I go up to the nipples, and also make sure it's been prepped even back, posterior, all the femur, the gluteus part, in case if you need to do femur shortening, so you don't have to struggle later on. So make sure you have a very good preparation and positioning for the patient, and this is the position you're going to stay with for a long time. Then we'll move to the incision. So we did the adductor tenotomy either with percutaneous or with the needle, whatever you're comfortable with. Recently, I'm very happy with the needle, especially for DDH, except for the CP. And how about the incision, bikini incisions? Thank you, Dr. Harris. So bikini incision and how we mark the bikini incision. So there is a landmark. You just don't imagine how the bikini looks like and makes a line. But as Dr. Ahmed said, iliofemoral. So yeah, I prefer the bikini incision because especially for these young kids, they need cosmetic incision and it's very ilioinguinal. And it's very easy to reach out to the pelvis, very easy to reach out to the hip joint. It's very versatile incision. There are two ways to mark the bikini incision. So one way is depends on your fingers. So 1 or 2 finger breadth lateral. Yeah, so Dr. Harris, iliac crest, ACES 2 centimeter below to the femoral and below to the femoral artery. 2 centimeter below to the femoral artery. Yeah, I go parallel to the iliac crest, which is 2 centimeters from the ACES, and I extended medially. You mean extended medially to the femoral artery? Yeah, I stop at before the femoral artery. There is another way. Texas Coach tried to make it in a way midway between the ACES and the GT. But yeah, you can see the crease, and based on the GT or the iliac crest, you go 2 centimeters distal to it. Then we open the skin, and what will be the structure you guys looking for after you open the skin? Lateral cutaneous nerve, fascia, lateral cutaneous nerve. So I make the skin incision. So when I do the skin incision, usually distal to the ACES, the skin is very thin and the subcutaneous tissue is very thin, but more proximal. Whenever you go proximal close to the iliac crest, there is more thickness and more fat. So it's okay to go deeper with a knife proximally, except you get some bleeding. But be careful when you go distal to the anterior superior iliac spine, because it's very thin and it's easy to cut the nerve in this stage. I use the Bovie after the skin incision to stop the bleeding. And again, I use tenotomy scissors distal to the anterior superior iliac spine, just to be careful. Then you look at the lateral cutaneous nerve of the thigh. If you don't see it, if you don't find it, don't spend or waste your time looking for it. If you don't see it, just start a little bit lateral. So what will be the interval you're looking for at this stage? I've seen Dr. Noor mentioned looking at the fascia. That's a good point. But what will be the interval at this stage distal to the ACES? Tensor fascia lata, sartorius tensor. So there is excellent agreement. So we identify the sartorius and identify the tensor fascia lata. Sometimes these cases are not straightforward and confusing. So to make some landmarks, if you get confused, because I see a lot of cases get congenital external rotation, so all the structures are external rotated. Even the sartorius is external rotated. So either you start to find the sartorius from the origin at the anterior superior spine, or you straighten the knee, hold the patella, then this will be the straight line of the rectus, and the interval will be above the rectus between the sartorius and the tensor fascia lata. If you don't find the lateral cutaneous nerve, make a small incision at the fascia over the tensor fascia lata and start from there. Don't try to go through the muscles. Try to find interval. It's amazing interval at this part, and usually you see some fat on it. Actually, at this dissection, I use retractors. And so I put 2 right angle retractors, one to retract the sartorius medially, and the other one is to retract the TFL or tensor fascia lata laterally. This would be enough to give you the interval dissection. You'll see some fat. If you go a little bit deeper with your retractor, you'll see the rectus muscle. Yeah, you feel the interval by your finger. So either with your finger, you want to feel the sartorius, you can get the interval, or if you want to start lateral to be safe from the nerve, then you get it from the lateral. But the trick, don't go through the muscle, otherwise you lose the interval. Tensor for your need femoral osteotomy. Can you proceed through bikini incision? No, if I need femoral shortening, I do a separate incision. I know some do the curved incisions or iliofemoral, but I don't do it in young children. I do separate incision if needed. Perfect. So now we did the bikini incision, we did the adductor tenotomy. We feel that the hip is going into the joint more easy with a closed reduction. and we found the interval between the sartorius and the TFL. What will be your next step? Straight rectus head. Perfect. Splitting the apophysis. Long head of rectus tenotomy. Opening the apophysis plus rectus. Perfect. So there is some sort of agreement for the next step. For my next step, I usually move up. So once I found the interval, I take a deep breath and then I go to the iliac crest. At the iliac crest, there will be the abdominis obliquus muscle covering, overlapping the crest, and it's very close to the abductor muscle. So I will open the fascia with Bouvi, and then I will peel off the muscle, not completely from the iliac crest, the abdominis obliquus, not complete peeling, but it's 3/4 of it from lateral to medial, making sure I have to repair this at the end. So peeling off the muscle to expose the iliac crest. Once I expose the iliac crest, then I do the subperiosteal dissection. There are two ways to do subperiosteal dissection. One, the most common one and the famous one is you split at the middle of the apophysis with a strong knife, and then I put some sort of sponges at the inner table and outer table. Inner table usually bleeds a lot because there is a feeding artery, and if this artery is not stopping, you can put a bone wax until you complete your dissection. Same thing. Make sure when you split the apophysis is to stay midline, and remember the iliac crest is curving, so it's not straight. I'll answer you, Dr. Abdullah, but if I found the lateral pectineus nerve of the thigh, I use a Sergi loop, but if I don't find it, so I just stay careful and I don't go sharp at this area. I have a pelvis model just to show you the iliac crest is curving. So every time you're going posterior, there's a curvature. So keep feeling it before you cut. Otherwise, you'll fall into the abdomen or you fall lateral. Then once you go into the muscles, it will bleed, especially with a knife. So after I split the apophysis, and now I go all the way down. Make sure when you go down, you see still the anterior superior iliac spine, and I go with the cob or periosteal elevator, whatever you have. I prefer the cob. So go subperiosteal until you go to the sciatic notch, the greater sciatic notch. One thing, avoid to go proximal. So sometimes you fell into the SI joint, so you don't want to do this. You wanna stay vertical and a little bit distal. So always your direction with the pelvic osteotomy is distal. And be careful and go easy. Use two hands on the cob so things will not slip posteriorly, and all the vital structures are in the sciatic notch. Same thing on the outer table. Subperiosteal, control the bleeding. Keep backing this with sponges. I use 4x8 sponges, and make sure you count them with the nurses for the final count at the end. Osteotome or jiggly. We'll come to this, Dr. Noor. Yeah, let's go step by step until we come to the osteotomy. I use Homans, blunt Homans at the sciatic notch. Make sure you stay subperiosteum. There are some steps in DDH or the pelvic osteotomies that can go very quick, and there are some steps that you have to slow down. So when you go at the sciatic notch, make sure you slow down, make sure you're careful, make sure you're subperiosteum. Use the homens, make sure the tips of the homens at the sciatic notch are touching each other from the inside and from the outside. And here's a sciatic notch. I'm not sure if you can see it
Yeah.
with a small camera. So this is the inner table. Sciatic notch. We put the homen in. And because of the background, I see the picture is not stable, but and sciatic notch, make sure both metals meet each other. And some people use radio translucent homens, which will be very helpful. We don't have it in our institute. For the pelvic osteotomy, Jiggly saw versus osteotome. If you do Salter osteotomy, so Jiggly saw will be better option. But if you do Dega or Pemberton osteotomy, then you need straight and curved osteotomes. Once I reach this point, then I'll go back to the first interval. We found the interval between the sartorius and the tensor fasciae lata. Then you go deep, and as you guys mentioned that you'll see the rectus tendon. So the rectus tendon has two heads. There is a straight and the curved head. So both of them are doing like Y. So I'm doing Y. So most of the time when I cut the rectus to reflected, so I go distal to the delta, all the Y, so I get to the main part before the straight and reflected head. So when I reflect the main branch, then it's easy for me to repair it after. So you find the tendon, make sure I use peanuts to find the tendon, both medial and lateral, and you expose it nicely, and you suture it. So either from the distal side only, I put a stay suture in the distal and the proximal side, because sometimes I lose the proximal when I do the correction. So it's easy for me to find it, or sometimes I tie both of them together at the same time at the end. And then when you hold it with the sutures, you start to peel it off from underneath using the peanuts. So at this stage, you'll clean some of the capsule. You'll see the capsule. Your guide will be the femur head because it's dislocated. So it will be under your dissection, and it will be your guide, and you start to peel off the rectus. What will be your next step, guys, after this stage? So now you have the iliac crest exposed. You reached the capsule, and you reflected the rectus femoris, straight head. Iliopsoas, and identify the femoral nerve, iliopsoas tendon, tenotomy. Dr. Ali said arthrotomy. Iliopsoas release, capsulotomy, removes the abductor from the capsule. Excellent point. So do you guys clean off the small muscles on the capsule, or you just do the capsulotomy right away? Capsule open. Perfect. I take my time to clean off the capsule from the small muscles, iliocapsularis or whatever muscles, and clean all. We clean it. Excellent. Remove the muscle first. Some surgeons do it, not do iliopsoas tenotomy, as anterior chakrin or barrier to anterior dislocation after capsulorrhaphy. So yeah, I clean the muscles of the capsule, and this is before I do the capsulotomy. So the next step after I clean the muscles, I found the psoas tendon, and the psoas tendon. Usually you see the iliacus muscle, and then the tendon is inside the iliacus muscle, and it's very important. I never done DDH case without cutting the iliopsoas tendon. It's very important to cut it, and because it's a block to your reduction. So I found it. It's inside the muscle. I used to so in Egypt you call it gallbladder, Dr. Muhammad. Okay, use a gallbladder forceps. So I used two of them. So I start to use them. They shuka وسكينة. Go inside the muscle, peel off the muscle, find the tendon, then get the gallbladder from the other side until you deliver the tendon out of the muscle. And I just cut the tendon. I tested to differentiate it from the femoral nerve with a little bit of Bovie touch to see if there is any jump, and then I cut it completely. Usually it's intramuscular and it's a glistening tendon. You guys know the tendon and you can differentiate it from the nerve. Femoral nerve is more superficial, and the psoas is more deep and lying on the capsule, so you can feel it. Excellent. Perfect. So we're going to the next step. With once I cut the iliopsoas tendon, it gives me a huge room to go inferior and medial. Make sure you continue dissecting around the capsule as far inferior and as far medial. And if you look at the picture here, will be at this area. So focus on this area. The capsule usually is hanging around there. So keep cleaning and at the top of the capsule all the way down. And you make separation of the capsule. I use the cob also to separate it from the abductors at the top. And I go a little bit over the top, but not too much posterior, so it won't affect the blood supply. So I go all the way there. And for the capsulotomy, I do the T capsulotomy. So first cut is vertical. So here's a femoral head. It's larger than what we see in the X-ray because there's a lot of cartilage on top of it. So I can just mark it here. But be careful when you start your first incision. You ask your assistant to do flexion. So the femur head will go more posterior. So I do a snip with a knife to start to open the capsule. And to remember, capsule is very thick, so don't injure the femur head. And once I do the snip, I bought a Kelly or Howard or septum or whatever you call it under the capsule, so it can protect the femur head. And I go all around with the knife, so it can make a straight cut here. So straight cut all the way inferior, medial, and almost all the way superior. Then the transverse cut is parallel to the femur neck. So I do the transverse cut, start from here and do the transverse cut. It will stop you the intertrochlear or the intertrochanteric notch will stop you. So it's going to be a very short T cut. What do you think about the tongue shape capsulotomy? Recently, there is a lot of new shapes of capsulotomy, tongue shape, rectangular shape, doing only one cut and get this over. I'm still with, McDonald retractor is helpful. Yeah, we call it here septum, Dr. Ayman, or Howard's, but yeah, it's a McDonald. How can you determine the site of vertical limb of T capsulotomy? It's just to stay, I would say 1 centimeter lateral to the labrum, so you don't cut the labrum. Perfect. So now where we did the capsulotomy, which is a T, and we need to open the pelvis. So what will be the surprises when you open the pelvis? So first thing you'll see is the femur head, intracapsular obstacles. So you see the femur head, and the first thing I would see is the ligamentum teres. So ligamentum teres hypertrophy, and also ligamentum teres is helpful to me because this is my guide to the true acetabulum, because here is a false acetabulum, so not to get confused. So I hold the ligamentum teres with a coker from here, from the head, and I cut it with a knife. Again, don't injure the femur head. And while holding it, I put my finger sliding parallel to it. This will be my guide to the true acetabulum. Then I use a long curved mayo to cut it very deep. So I go with the long curved mayo parallel to it until I go inside the acetabulum and I hit the bone. And with the curve, I cut the ligamentum teres. After we do this step, then we keep the hip dislocated, so we'll give you more view to the acetabulum. You can also use deeper right angles at the anterior acetabulum. Make sure you see everything and visualize it. Visualize the pulvinar fat. And once you see the pulvinar fat with the Carrison or with a pituitary rongier, so we start to peel off the pulvinar fat very gently. Don't injure the cartilage, but just anything that comes easy in your hand, this is what you need to dig out. Excellent. We have very good questions, but I will just continue to go through the steps, and then we'll determine the redundancy. Dr. Noor mentioned that there is the transverse acetabular ligaments. Now I cleaned the ligamentum, hypertrophied ligamentum teres, and before that we cut the iliopsoas tendon, and I removed the pulvinar fat. Use the peanuts, gently look inside. Always remember this is a joint that has cartilage in, so don't like be rough inside. Just use the gentle stuff and save it for the future, because our main goal is not to make the X-ray look good, but also we need to protect the skid from having osteoarthritis in the future, so we're doing our best. And the transverse acetabular ligament is holding the acetabulum from the inferior part. So carefully with the McDonald retractor, go around it until you feel it, and that's usually very tight. And the McDonald retractor itself can protect you. So I go around it and from inferior hold the McDonald retractor. Once I make sure that I'm safe, I use the pulvinar fat, then I use the knife to cut on top of the McDonald retractor as a protector. After this, I will see how the reduction looks like. So we get the hip into the joint, and we know the deficiency is usually anterior and lateral. So most of these kids, the disease is, no, I never need to do a radial incision to the labrum, Dr. Ahmed. So we do the reduction and then assess the safe range of motion and or the safe zone of Ramsey, and we'll see how at what degrees the hip is going to dislocate, and the amount of adduction and also the amount of extension and deflection. If you feel the reduction is super tight or you're not able to reduce it, then this is the time that you open lateral approach and do the femur shortening. If we need to do this, always a question, what's the amount of femur shortening needed to be done? I go with the overlap technique. I know some people do pre-op planning, but I go with intraoperative decision. I bought the plate. I get the 4-hole small fragment plate, and I bought or 5-hole. So I bought 2 screws at the top, and I drill before cutting. And after I drill them, then I remove 1 screw and I loosen the second one. I flip that plate at the top, and then we'll do the first cut. Then they get the overlap. We do the reduction, the amount of overlap with the reduction. This is the amount I need to cut. So it's usually a centimeter, maximum 2 centimeters in older kids. I don't excise the redundant capsule, Dr. Ali. No, I don't do Colonna procedure, and I'm not sure if anyone is still doing it. So once I do the open reduction and I make sure there is no obstacles from anywhere that's blocking the reduction, and it's okay to get X-ray done, then I'm happy with this. Then I start to put my sutures for the capsulorrhaphy. As I mentioned, I use something called orthocord, and I use number 2. So I pass the sutures. The first suture is very far inferomedial. I get a very good bite. Even feel free to bite the bone as well. This will be the most important suture for you. And if you imagine with me that you have a T capsules and you have a triangle of capsule here remaining. This tip of the triangle, I wish I have pictures. This tip is the one that you want to shift it down there. So you get this tip here to be shifted all the way down. And this is what Dr. Salter used to say, capsular shift, or the capsulorrhaphy is like capsular shift. This will tighten the whole thing to come more medial. So you get the superolateral to the inferomedial. And this is the main suture. Then we do another suture here to get above it, and a third suture there. I forgot to tell you, when I do the subperiosteal dissection laterally, I like to do with the cob. I peel off the capsule that's attached to the false acetabulum. This will help me for 2 things. Number 1, I found I have less patient need femur shortening. Number 2, I found it easy to find the entry for the cut for my pelvic osteotomy. And I use 1 suture, and that's me only, but you feel free not to use it. And that's a good answer for the redundant capsule. I'm not a big fan of excising the capsule, but I do a strong suture at the part that I remove the labrum from here down there. So I do 1 suture from proximal to distal at the end. So I use 4 sutures for the capsulorrhaphy. In case when the head is double size, the acetabulum, what's the solution? So if the head is double size or large, which is it's quite uncommon, so there should be something happen. So either it's a revision, or patient had kind of AVN after closed reduction or something. So I'll go case by case, but and that's another good reason to do these cases as soon as possible. It makes a big difference. I'm very rarely faced a large head. So if you say large head reducible and it's concentrically reduced, then I will try to do a very good pelvic osteotomy to cover it, or shelf. If it's irreducible, then I do shelf or carry. Do you make release of abductor from capsule to prevent recurrence? So when I go with the cob to clean the capsule of the muscles, and at the front, I also go a little bit superior or proximal to make a little bit of interval easily I'm very sensitive to the abductors because abductors are super sensitive and they get weakness very quickly. So I don't do aggressive dissection, but if this is your primary surgeon, this patient hasn't done any surgery before, it's super easy to go through the interval gently, bluntly with peanuts or with cob. You guys are asking very good questions. It seems like most of the people are doing DDH a lot. So DDH are just too many steps. Every single step needs to be done perfectly, so we can get good outcomes for the future. And there are some steps you have to be very careful, especially going at the backward or posterior and the blood supply. And there are some other steps that you can go very quick. Perfect. Now I tried the open reduction and I reduce the hip and I do a picture with X-ray. And then some people do the capsulorrhaphy now and then do the DEGA after. I prefer to do the DEGA first and then capsulorrhaphy for deficient posterior acetabulum. I would leave it to the next case. So we can, this is a pure DDH and the deficiency is anterolateral, but I have a case with posterior deficiency I will show you right now, if you guys are still awake. So I did tried the open reduction, then I dislocated again. Some people argue, say, it's better to keep it reduced, so when you do the DEGA, it will reshape on top of the head of the femur and also will guide you for the limits. Sometimes I'm very aggressive with the DEGA to make it more horizontal. I'm fine with the dislocation. It gives me more freedom to do the DEGA and put the graft, and then but I put the sutures first. So once I do the DEGA, I'm ready to do the reduction and do the capsulorrhaphy right away. So go to the next slide. When we do the DEGA osteotomy, so I go a centimeter above the edge of the acetabulum. Some people go a little bit more lower. I just, yeah, I'll answer you, Dr. Ayman. So some people go a little bit lower, close to the acetabulum. Just be careful to go close to this edge because you have the secondary ossification centers here. And this might affect the remodeling. And that's why some people wonder why this patient, I did a very good DEGA and they had a recurrence and the acetabular index went back high. So just don't go too low. I used to go 5 millimeters above and you get nice, decent acetabular index. But recently I started to go a little bit higher. This gives me a little bit of kind of shelf at the top of DEGA, so I get extra coverage in some cases. So go with the straight osteotome first. I wish I have the steps, but I go with the straight osteotome until the middle of the ilium, and I take it out, and then I go with the curved osteotome, and I stop about 5 millimeters above the triradiate cartilage at this corner. So aim it to this corner, and you stop there. And because from the outer edge of the pelvis, not sure if you guys can see this, it's very wide. So the osteotome goes at the middle first.
دكتور وليد بيه، انا ممكن اكلم الشركه توقف الخلفيه بحيث ان حضرتك نقدر نشوف. ايه راي حضرتك؟
يا ريت.
دكتور مايكل حضرتك معانا؟
يس دكتور مع حضرتك.
ممكن نلغي الخلفيه بتاع دكتور وليد بيه عشان نشوف الهيب بون؟
هو دكتور وليد يقدر يعمل ده من عنده.
مساء الخير دكتور وليد. مساء الخير دكتور محمد أشهب. شكرا
فاضل
جزيلا.
بيه، ازيك يا استاذنا؟ اهلا بيك يا فندم.
الله يخليك، سعد بالمحاضره الجميله دي واليوم العلمي الرائع.
محمد ازي حضرتك؟
ازيك يا حبيبي، ربنا يديك الصحه، كل سنه طيبين. اقترح على حضرتك اسهل تخليها قدامك على صدرك لانك لبسك غامق فممكن تظهر. ايوه
اوكي.
كده.
Yeah.
اسهل.
حتى لو عملت
Yes.
so here is a
كله ده واضح تماما.
yes.
Yes. Yes, sir.
شكرا دكتور محمد.
الله يخليكم.
هنا الاستابلم. Yeah. When you do the osteotome, you need like the osteotome usually is a half inch goes for 1/3. So I start at the middle third, and once I finish the cut, I use a little bit bigger osteotome, and I start to go more posterior to do the posterior part, and the posterior part has most of the bone, and that's very important. That's why I prefer Dega, and that answers the question for Dr. Ayman, even if you have, or Dr. Ahmed, if you have posterior deficiency, Dega is very versatile. If you want to cover more posterior, if you want to cover more anterior, then I put the graft either anterior or posterior. I use Carrison, so I can cut the anterior part of the iliac crest and line with my Dega cut. And I use the Carrison posteriorly and make sure that I'm safe subperiosteum using your Homans, and I do a bite to cut the posterior edge at the sciatic notch. So one bite at the top, one bite at the bottom, at the posterior part. And that's the difference between Dega and San Diego, and people doing San Diego are doing this part to make it a different technique. After you complete your cut, then I use the osteotome to stretch it slowly. Yeah, I don't do Salter anymore, Dr. Ahmed. Although our neighbors in Sickets in Toronto, they still like to do Salter because this is his home. So I go with the osteotome, I go down, and then I replace it with the lamina spreader. There are too many types of the lamina spreader. Try to get the non-toothed lamina spreader so you won't crush the bone, and go very, very gently and be very careful. Then how to get the graft. So I use autograft from the pelvis. If I do femur shortening, I use the segment of the femur to use it as a graft, which will be very easy. But if I don't do shortening, I take the graft from the iliac crest. There are two ways to take the graft, either horizontal, like this, to get a triangle after you measure the distance that you need to do, or some people do it vertical, this way. And it's a very nice, size of the graft. You measure the size, width, and depth from here, and also the length. So I use the intraoperative measuring tape. It comes in our drapes anyway. So I have tape, white paper tape, so we can use it intraoperative. You hold it with a mosquito. Then I measure the graft and I mark with the saw, and then I do my V-cut. I like the vertical one because over time it doesn't cause deformity. And it's gonna be filled with bone. So cosmetically it's better. Although when you do the horizontal part, it's not bad idea as well, because after you move everything, you feel like the ACES is more prominent than before surgery. But anyways, it's not a controversial point. Once you get the graft, you put the graft inside and you fill it. And once you get a decent correction of the acetabular index. I kind of tend to get overcorrection a little bit for the acetabular index, although I measure the index that needed from the normal hip, so I can try to match it. But if you go a little bit more, it's better, but not too much more, because there are some reports of subsidence of the grafts and can get crushed a little bit, so you lose it if you do too much tension. The graft is in, it's from the ilium, and I did X-ray for it's very hard with C-arm, but you try to match the acetabular index, and make sure it's very stable. And after this, we do the capsulorrhaphy. So the same suture we did, the 3, I suture them tight. When I get to the edge of the capsule here, I try to slide it more medial. So don't try to slide things medial to lateral, because it won't, but slide things from lateral to medial. And this is what Dr. Salter initially mentioned as a capsular shift. DEGA start 1 centimeter proximal to IIS. So I start DEGA with a fluoro. So I go 1 centimeter above the proximal edge of the acetabulum. So I don't mark it with IIS, but I think this is the start point of Pemberton. So start 1 centimeter from the AIS because it's more anterior. But DEGA, it's more lateral. So I mark it with a fluoro. Once I feel things are tight now, I'm very careful with the stability test after capsulorrhaphy because I don't want to weaken or loosen the knots I did. But once you do every step careful, you're fine. Unless it's very unstable, it's going to be very unstable. And if it's very unstable, I know some people put a pin. I hate it. Some people put the pin from the GT to supraacetabulum. I never had to do this. I hope not to do it until the end of my career, but it's one option. Another option, which is being mentioned, is to do a kind of tightrope in certain cases of Down syndrome or really unstable hips or in congenital short femur. Then you wash and irrigate. I use normal saline for wash. I use 1 liter of irrigation, and then I start closure. I start with the apophysis, get the apophysis back, make sure it's matching nicely. Start from the anterior superior iliac spine. Some people use a towel clip to bring it together and do your sutures. Use number 1 Vicryl to close it and make sure it's matching, not inverted, not externally rotated, because this is a growth plate and this is apophysis and this needs to grow. And there are some reports that causes deformity in the future for the pelvis, especially a new paper came from San Diego recently as a long term, but it's cosmetic mainly. One of the other cosmetic things that I would advise you not to do is to do the incision at the iliac crest itself. It causes very bad scar, and you see how deep it is going down, and the people will hate this. Once I close the apophysis, then I start to close the abdominis obliquus muscle. So get the deep layer to the muscle as far lateral, close to the abductor, and then I get the fascia also separately. Just try to avoid any hernia that happen from this defect. After that, I will get the straight head of the rectus tendon to be the one that I reflected. Then I suture it back. Doesn't have to be super tight. And then you suture it back to the origin or the small part that you mark. But as I mentioned at the beginning, I mark both ends. And then you get a careful couple of sutures at the interval that you did for the fascia. Don't do it super tight because you might not see the lateral cutaneous nerve of the thigh, and then you do some impingement with your suture. Then I use 2 Vicryl for the subcutaneous tissue, and I use 3 monocryl subcuticular closure. We use monocryl subcuticular closure for all children up to the age of 18. And then I leave the tails out. Some people do not, which is fine. Use the steer strips and then sterile dressing. I keep holding the hips. I don't let go. And then I get a picture before we take the drape off. I'm the person who will keep holding the hips. My fellows and residents will take the drape off gently and also making sure we're safe, taking the Foley off. And this step has to be very careful with it. And then get the spica table underneath. You left the patient with them, get the spica table under, let the anesthesia guide this and lead this and count when you lift the patient up, so you can take care of the tube. Then once I get the hip spica up, if you have a cast technician will help you, or your fellow is very good, then they will do the cast for you. Spica cast done. Salter said 30, 30, 30, 30 abduction, 30 flexion, and 30 internal rotation. I do a little bit more, so I go to almost 60 degrees of flexion, and I go to about 30 degrees of abduction and 15 degrees of internal rotation. The reason I go with flexion more, because a lot of people here ask for the car seat and stuff, so I can make it easy for them, and I don't have any problem. Is it mandatory the fluoroscopy when do DEGA osteotomy? Yeah, I use fluoroscopy when I do DEGA, and I know some people try to do it percutaneously. I try to avoid injuring the triradiate cartilage, and it's good also to get your entrance point and mark it. So I use the fluoro for it. We applied the spica, and so good padding. I do 1.5, so I don't do bar between them. Some people do. I go as high to the nipples, and I keep the spica on for 6 weeks. I see the patient in 2 weeks, get X-ray through the cast, and then in 6 weeks we take the spica off. I have a ready abduction brace at the clinic, so I apply the abduction brace right away because they cry, scream because of the stiffness once we take the spica off. And I keep it for 23 hours for about 2 weeks until they feel better, and then they start walking. I delay physiotherapy for about 3 weeks until they're comfortable, and physiotherapy mostly is hydrotherapy to get the range of motion and avoid the stiffness. In certain cases, when I feel that they're very unstable, I use the abduction brace at night for 6 months. If they're fine, I don't use anything afterwards. I don't do the A-frame after with the cast and or the broomsticks cast afterwards, because I found it causes more troubles more than the benefits. And I prefer if we get flexible, more range of motion of the hips than stiff hips. Also, one of the disadvantages of the A-frame and the broomstick cast, it causes weak supracondylar. So when they go to physio and start range of motion of the knee, they come back to you with a supracondylar femur fracture. Most of the cases we faced excessive femur anteversion. So for femur osteotomy, I don't think so. Most of the kids already have femur anteversion at this age, and we call it physiologic femur anteversion. So it's either the length or not. The cases I do derotation osteotomy usually are recurrent and revision cases, and they get excessive femur anteversion that stays usually above the age of 8. And it causes significant discomfort and sometimes anterior labral tear. So these are the cases I do derotation. There is the X-ray of the patient at 5 months post-operative, which has a lot of constipation. Any questions?
Professor Walid, after such cases, you don't get some form of femoroacetabular impingement in the older age?
In these cases, usually not, because they get remodeling, and here's a sourcilius stop there. But in some cases, I found the cases that get femoroacetabular impingement who are mostly Berthes cases that had Salter. So they do excessive Salter in older age, and then they get acetabular impingement. Or if you do, like, as I mentioned, sometimes I do DEGA plus a little bit of shelf. So if I go too much with the shelf, it might cause impingement. But it's very rare with the young kids. They remodel. They have a very good time with very powerful remodeling. But yes, for the older kids, I would say be careful for kids above age of 6. Thank you, Dr. Ayman. You guys are experts. What about of percentage of AVN? So AVN reports are very variable because there are different degrees. So if we think about the bad AVN, type 4 are very rare. The most common is type 1, which is something very small. Most of the kids you see over time, their femur head becomes bigger over time and larger. The worst one, in my opinion, is type 2 because they get stop of growth laterally and they keep growing medially and causes caput valga and they get dislocation at the age of 11. So keep following them. Type 3 is very rare. Type 4 is very rare. And I think if we have type 4 a lot, we have to revise our technique and we need to be more gentle because it can be iatrogenic. There is a debate, is it AVN or is it growth issues? So Dr. Salter, the classification came from Kalamshi Salter in 1981, and Kalamshi was his fellow at the time, and he made the classification of type 1, 2, 3, 4, and there was a debate in the time that it's more growth issues more than AVN. Do you face post-reduction hip stiffness? I have very, very low percentage of hip stiffness, Dr. Imad, and that's why I'm saying 6 weeks is enough. Don't do cast more than 6 weeks. You feel like you get more stability, but stiffness is too bad. It causes limping, and it's very difficult for physiotherapy to deal with children, and also very difficult for kids to respond to stiffness for a long time. I believe, but I have no evidence that hip stiffness is something can be racial, because I see some sort of nationalities are more prone to stiffness more than the others. I feel like I see some nationalities are more prone to redundancy and laxity and hypermobility more. So I don't know if genetics can do some good work on this. Any other questions on DDH? So in summary, I do the surgery as soon as possible. If there's 6 months to 1 year, I do close the reduction arthrogram. And these are the kids. I take 1 shot of CT with the O-arm intraoperative just to with a very, very low dose, so can make sure that Shenton line is reduced anteriorly in the axial cut. And then these are the kids I keep the spica on for 3 months when I do close the reduction. I change it in 6 weeks. But I have low threshold to do open reduction pelvic osteotomy at the age of 1, starting from the age of 1. This might look too aggressive and compared to the other people, even here in Canada, but I still believe on this. What's the earliest age you can do pelvic ostomy? I just mentioned 1 year at the age of 12 months. They get pushed by the wait list anyways, but try to box them by 1 year. Does radiological irregularity at the superior edge acetabulum means something about prognosis? No, that's a very good question, Dr. Mohammed. So these irregularities in 5 months are expected. So things are not looking great in the first year, but this is normal to me. What about causes of reduction, failure, post-operative, and failure of remodeling? So that's another topic. So one of the things, try to get, when you do the Dega osteotomy, try to do a little bit of overcorrection. Germans make it horizontal. Like the person who taught me Dega was teaching me to go horizontal because he said the remodeling. Then I followed him for some time. Then I start to see when I go too much, then they get more subsidence. I found it's reasonable to get like reasonable acetabular index, and then I don't do too much stress on the graft and then remodel. Doesn't mean he's wrong, but this is what works with me. And I feel happy when I see this edge. That means the center of growth, secondary ossification center, is working, and this is causing more remodeling. There is a lot of debate how to measure the acetabular index. Is it to the sourcil or to the tip? And I was a reviewer for a study recently, and I was happy that they provided evidence that the tip is more accurate than the sourcing, especially at this age for the Stabler index. You get these irregularities. These are from the graft because the cut started from here and you opened, and this is a graft. So it's usually this remodels. You see some irregularity from the graft itself. This is the one that the study came out, said some people complain from some growth disturbance, and it's mainly cosmetic. So that's why people want to change splitting the apophysis and go from lateral and get the apophysis as one piece. They found this less cosmetically causes a problem in the future. And also some people recommend getting the V more vertical than horizontal. But again, these are not functional issues. I've seen a couple of kids get myositis ossificans around the graft. But again, once you're careful for the abductors, treat the abductors with a big respect because the abductors are super sensitive and can cause significant functional abnormality. So ideal Stabler index, there is a table with matching with the age. So it's under the age of 1, it's under 30, and by 24, it has to be 24 months, it has to be 24, and it keeps going down over time. Intraoperative, preoperative decision to do femur or pelvic osteotomy. I always do pelvic osteotomy, and the femur osteotomy, I do it only if the reduction is impossible or it's after reduction it's very tight. Which one is more important determinant of the need of femur osteotomy, upward migration or femur anteversion? The upward migration, Dr. Bassem. Don't worry about the femur anteversion. How much a Degas osteotomy can decrease a Stabler index? It can get it down to about 25, sometimes 30 degrees. Perfect. So are we going to move to the next case? So this patient is 12 years old. She is a cerebral palsy, GMFCS level 2. She's very functioning. She's walking. She did SDR surgery before, selective dorsal rhizotomy, and that made her function amazing. Less spasticity in the lower extremity, although she came with the right hip pain. So how you guys approach this case? Really open reduction. Pelvic osteotomy, Walker, yes, GMFCS level 2. She's ambulatory. Why in little bit of cases show failure of remodeling many years postoperative, like subluxation or coxa magna? Coxa magna can be AVN, and subluxation, this can be lack of intraoperative judgment, or if it's early postoperative, it can be due to confusion of the follow-up X-rays and examination. So back to this case, coxa valga, VDR over plus shelf, adductor tenotomy, pelvic osteotomy, varus osteotomy with Dega, right side, CT scan first, triple osteotomy, coxa valga. Yeah, there's coxa valga, Dr. Imad. So in CP, these are the cases we do VDRO. These are the cases we treat the anteversion and also the valgus. But can you imagine here if I do varus, this would be enough for this acetabulum? As some mentioned that pelvic osteotomy. So adductor iliopsoas STO. So yeah, so I took the patient to the OR, patient sleep. Actually, unfortunately, this patient, I took her in December, and when she sleeps, she had bronchospasm. Anesthesia was was very concerned, and then we canceled surgery. And then we did the surgery 2 weeks ago. Typically for these kids, they have posterior acetabular deficiencies. They have significant coxa valga, but this kid is ambulatory. So I usually go aggressive with the varus osteotomy, get them down to 100 or 90 degrees of varus, but not in this one, because if I do significant varus in her case, she might not be able to walk. So adductor tenotomy, in these cases, I do it open because they're CP, and because she's ambulatory, I only do the adductor longus. I avoid the adductor brevis, so she can continue in a good function. Thanks, Dr. Abdullah. So yeah, that's excellent. There is retroversion and acetabular posterior deficiency. So after you do the adductor tenotomy, and sometimes the gracilis are tight as well, but I try to do the minimum for adductor release in ambulatory kids if she's a walker. Then we did the varus osteotomy. Before you do the varus osteotomy, I did the range of motion under fluoro to see what amount of abduction I need to do to get enough coverage. And I do a little bit less than what I see because she's ambulatory. So always keep in mind that she's ambulatory. Even for the psoas release, don't do it from the distal part, do it from the pelvic brim because she needs some flexion for the function. Subtrochondric varus derotation, and triple or PO. Excellent, Dr. Ayman. And this is what I thought of doing triple or PO because her triradiate cartilage is closed. So DEGA might not work. Some people say DEGA works in CP because their bone is soft, and then you can do hinge on itself, even with the triradiate closed. But it seems to be very mature. So triple or PAO or Gonzo osteotomy would be ideal for me to get this coverage. But the primary disease in these cases, actually not the acetabular. The acetabular dysplasia here is secondary, but it compares this to the first case. The primary pathology in the first case is pelvis, the acetabulum. The primary disease in these cases is the femur. So if you want to start with something and the anesthesia stops you because of any complication risk, start with the femur, so you did something to this patient. So I did the intraoperative fluoro. This is amount of abduction. So I was able to get to 30 degrees abduction to get a decent coverage, but you see the acetabular index is very shallow and it's almost vertical. It's about 70 degrees. So I started with the VDRO. So I did the same angle as I measured. I did about 20 degrees of varus. So I didn't go all the way with 30 degrees. And I did derotation as well. And when you do the derotation, there are too many techniques. I'm not a big fan of CT to measure the amount of antiversion, retroversion, or whatever. But I go clinically. So after I bought the screws, I make sure I bought these screws at the normal antiversion angle. And then I put the screwdrivers on it, and I measure the angle of the screwdriver to the femur condyles. So this will be the amount of antiversion I needed. But at the end, I want to make the patella facing the ceiling, not internal rotated. Primary pathology of CP patient is a muscle imbalance. Thank you. And then after that, I felt like this patient needs pelvic osteotomy, and I feel like DEGA wouldn't be working in this case because there is no triradiate cartilage open, so there is nothing to hinge on. So triple is a good option, and GONS is a good option. I felt like GONS is better because it keeps the posterior column intact, so it's good for the stability. So with the Gonzo osteotomy, it's simply 4 cuts. When you guys ask me if I do Salter, so part of Gonzo
دكتور وليد. لا سوري يا فندم، دكتور وليد الشحن بتاع اللابتوب خلص، بس بيجيب الشاحن ثواني يا فندم. He will recharge his laptop. Just 2 minutes. دكتور فاضل, just 1 minute. Dr. Walid is bringing his charger. واحنا بعد ما نخلص ان شاء الله محاضره الدكتور وليد، يعني بناء على رغبه بعض الزملاء، ان احنا هنعيد الورك شوب بتاع الدكتور جمال حسني. We will replay it again. كان في technical problems فيها. We will play it again.
So sorry again for what happened.
Thank you, sir.
صحن كان يظهر على الآخر وأنا I didn't notice. So if you guys wanna continue, so this is what we did. So was a PO, and as you know, PO simply is kind of modified triple. So we do the first cut at the superior pubicremus. Second cut is actually half cut at the ischium, very proximal, and we directed more proximal but incomplete. And then the third cut is kind of incomplete Salter. We stop 1 centimeter just more superficial to the iliac brim. And then the fourth cut is connecting the ilium to the ischial cut, maintaining the posterior column intact. Just to summarize, pelvic osteotomies can be redirectional osteotomies, or reshaping osteotomies, or salvage or augmentation osteotomies. So if you have a case that you can get a concentric reduction and the hip can be inside the joint, so we can do redirectional or reshaping osteotomies. But if the case is irreducible, this is the time we do salvage, and salvage can be either shelf or carry osteotomies. A little bit about Salter osteotomy. Salter osteotomy, as I mentioned, I don't do it anymore, but it's still a good osteotomy, and it's a valid osteotomy. What you do is the same approach as we did for the first case, but you use a jiggly saw, so you can do a complete cut. People say between the ACIS and AIIS, or a centimeter and a half above the AIIS. And then you do the anterolateral coverage by moving this distal piece down. Hinge is the symphysis, and it can give you about 10 to 15 degrees. Dr. Salter said he was able to get to 20 degrees, and then you have to fix it with pins. Make sure you're not intra-articular, and when you fix with the pins, you probably need to remove the pins at certain time. Here's a graft, and he's taken it from the iliac crest as we did in the first case. Here's an example of bilateral Salter. It looks nice, and there is a nice remodeling. Triple osteotomy went through different stages. So when Salter is a redirectional osteotomy, it depends on the symphysis. But if the kids get older and you're not able to get a hinge, because this hinge starts to be stiff by the age of 8. So it's very hard to get a good coverage by only Salter. People did double osteotomy and didn't work. And then they talk about the triple osteotomy. Steele did the first triple osteotomy, but he did the ischial cut very medial. And then he found that there's some limitation to get coverage. And then Lucour did the second one a little bit proximal for the ischial cut. Although it's interesting, the superior pubicremus one usually is the same. And then Tunis from Germany, his interesting name. His name is Tunis, but he's not Arabic. So he did the proximal cut, very proximal, and he got the best coverage. And when he got this coverage, the reason was because of the ischiospinal ligament was here. So people used to do the osteotomy distal to the ischiospinal ligament, and then this ligament is super tight. So it affected the correction. So you were not able to do it. Tunis was a good friend with Gans, and Gans from Switzerland, Tunis from Germany. They used to do a lot of cadaveric labs, and Gans thought about the Gans or PO osteotomy by saying, oh, how about if we do this incomplete and do this incomplete and connect both of them and get this rectangle out. And this is how it came out with the Gans osteotomy. So the Gans osteotomy is to do one like Salter, but you stop above the pelvic brim, and one pubicremus cut, similar to the triple. and one incomplete ischial cut. And then you connect both of them, the iliac to the ischial cut with a vertical one. So once you do these cuts, you have a free segment. But if you notice here, you have this free segment that covers the head of the femur, but the posterior column is intact, and that's the advantage. So these people have more stable, see the posterior column intact, so they have more stable osteotomy compared to triple osteotomy. Another advantage of Gans osteotomy compared to triple is it's very hard with the triple to manage the retroversion of the acetabulum, but it's much easier with the Gans, and Gans is very powerful. So when we do the correction, we use pins here, threaded pins, to do internal rotation first before I get the lateral and anterior posterior coverage based on what's the case I have. In CP, I do more posterior coverage, and it's very, very malleable in your hand. It's very good, versatile osteotomy, although it needs some sort of training approach with this. I did a bikini approach similar to the first case, and I did rectus sparing technique, so I don't remove or peel off the rectus. And I didn't open the capsule, so that was not open reduction. And to reach to the ischial cut, to use the Gans osteotome, you make sure you go to the inferior part of the capsule. It's a soft spot. I go inside with the cup until I hit the bone. I confirm with the fluoro. In Switzerland, they say they don't use fluoro. I found it very complex to me if I don't. So I use a fluoro. I get the ischium incomplete cut with the Gans osteotome. You do the cut posterior and then middle and then anterior. When you do posterior, you're so close to the sciatic nerve. There is a high chance to get a sciatic nerve injury. So you make sure you do it in extension. When you come anterior, you're close to the femoral nerve. So make sure you do it in flexion to relax the femoral nerve. When you do the iliac cut with superior pubicularis, the superior pubicularis cut, you feel like it's the safest one. The obturator nerve is at risk. And also the corona mortis is here, so it's very risky and needs a long training. So I use a saw to do this cut, which is a vertical incomplete cut, and then another Gans osteotome. I use it for the vertical cut. Use a fluoro oblique in about 55 degrees. That shows me the true pelvic brim and the pelvis from the inside. Here is other pictures of the Gans osteotomy, and see how it is very powerful and gives you a lot of coverage. Here's a approach, iliacus muscle, and iliocapsularis around the capsule. This is what we talk about at the beginning. Gans osteotome used anteriorly, and this is the one for the ischial cut, and this is infromedial to the capsule. Then I use the saw to do the Salter cut, if you want to name it, incomplete Salter. So use the saw. Then another osteotome to make it vertical. This is a very perfect view, and this is a cut we did initially. And superior pubicularis cut is you do it through the same approach. So I do all from the same incision, the bikini incision, and I do the rectus sparing. So I keep the rectus and I keep the sartorius. So I do a little bit of ACES, get a little bit of the anterior superior spine chip of bone, then I repair it again. Be careful with this part because you can get inguinal ligament and you can get inguinal hernia. Here is a triple osteotomy, which is, if you do Gans, it's easy to do triple. So instead of doing the incomplete cut, you do complete Salter, and you do complete superior pubicularis, and you do complete ischial cut, and then this whole piece is freed for you to get the coverage. Pemberton osteotomy, as someone asked me, so said the entrance is above the anterior inferior iliac spine. So anterior inferior iliac spine, 1 centimeter above. And this is the one that you probably can do it without fluoro, but I do with the fluoro. So we start your cut from the anterior part of the acetabulum. And you cut the anterior table, the inner table, sorry, and the outer table. And you stop above the triradiate cartilage by about 5 millimeters. I try to stop even more. There are some reports saying when you stop close and you do extensive Pemberton, and then you can get a risk of facial closure. And if you get facial closure, can cause different dysplasia in the future. And these are the cases you might see a larger head in a smaller acetabulum, as I get the question from Dr. Iman. Patient position for guns. It's the same supine position with the pump underneath. In case of hip dislocation, CP dislocation, you need to open reduction like DDH. Or so most of the cases in CP, you don't need to do open reduction. You just do VDRO first, is do examination under anesthesia. You do the soft tissue, and most of them don't need open reduction. If you see your reduction after VDRO is not optimum, it's okay to do arthrogram. And a few cases needs open reduction, but it's not the standard. Then the advantage of Pemberton is you can get anterior coverage. It's already in the same plane of the anterior. Your hinge is the triradiate cartilage, so you need young kids to do it. So you can get a hinge, a soft hinge, and then you get the graft again and apply the graft inside. You don't need bends for the Pemberton osteotomy, but in this demonstration, it shows bends, but you don't have to. Because it's a very stable osteotomy, similar to Dega. Dega osteotomy or San Diego or whatever you call it, Paley modification of Dega, it's all Dega osteotomy. It's all the same, and this is what we described in the first case. So here's a patient position, and you do the Dega. I start with straight osteotome. I start a little bit higher than this demonstration because as I mentioned, I get better coverage. And but Professor Al-Ashab mentioned a very good point that try not to get over coverage so you can face femoral acetabular impingement in the future. So you do your cut curved, make it parallel to the acetabulum. I stop 5 millimeters above the triradiate cartilage. And then with the osteotome, I bring it down there. And if you see from the side, and that's a difference. So you cut only the outer table, not the outer and inner, but you cut the outer and inner at the top and at the posterior. So anterior and posterior was the Carrison number 3, the one that the spine people use. And this will make it San Diego. If you don't cut anterior or posterior, this is simply Dega. So there is no big difference. With Paley, he did extension of this more posterior, so he made this more vertical. So he thinks that he can get more posterior coverage, a true posterior coverage, and he named it Paley modification of Dega. And so we get the cuts, oblique cut. It's beautiful to do Dega because it makes a acetabulum looks curved, so it looks like a socket. Compared to Salter, when you do Salter at the beginning, it doesn't look as nice, but Salter remodels at the end and it looks nice at the end. Then once you do this opening, you measure for the graft, you measure the width, depth, and length, and then you cut the graft from the ilium. And you put the graft in. You have the chance to put more graft anterior, more graft posterior based on the case. That's why I said I'm old enough now. I want to stick to one technique that fits DDH and CP and everything. So I found Dega is the one. So what's the difference between Dega and Pemberton? So the difference is Dega is only outer table, and Pemberton is outer and inner table. So it's only the trajectory and the direction of the cut. So Dega you start lateral, and Pemberton you start anterior. Pemberton inner and outer table incompletely. Dega you only cut the outer table, and you don't cut the inner table. With advantage, Pemberton only gives you anterior coverage, doesn't give you posterior coverage. Dega can give you both because your cut is coming from the horizontal direction. Again, so redirectional is like Salter, triple, and Gons. Reshaping is anything hinges on the triradiate cartilage, and there is a lot of argument about reshaping decreases the size or the volume or increases the volume. We think this is decrease the stabular volume, although there is a study published in JPO 2006 from Turkey saying that volume actually increased with Dega, but it's based on less than 10 cases. So it's there is no much power in the study, but again, it's a very interesting finding. But I found this very academic discussion from the clinical experience. They're doing excellent with Dega or any kind of osteotomy. If I want to focus on one thing in DDH, I focus on the open reduction. The type of osteotomy is not my main concern. If I want to focus on one thing on CP, I will focus on VDRO, varus derotation osteotomy of the femur. This is the main one. Then the salvage or augmentation osteotomies, I think it's too late to talk about this. I think we talk about the most important two topics and the most common two topics of reshaping and the redirectional today. For CP cases, did you do hip spica? I don't do hip spica and CP because they have a lot of complications with the spica. So I either use the A-frame, and recently I use the abduction pillow. How you hold the graft in Dega osteotomy in its position. The graft is very stable, so you don't need bends because it's incomplete cut. So they hinge on the graft and they hold it. If you casting for how long and when you start with weight bearing, that's for DDH or Dega or CP. So I assume it's DDH. So I cast a hip spica for 6 weeks, and I start weight bearing when the kids decide. So anytime, usually after 2 weeks. In CP, I don't do cast. So weight bearing usually at 6 weeks. When I see radiological signs of healing.
حضرتك فكرتني يا دكتور وليد بيه اول ايبوس حضرته من حوالي اعتقد دكتور فاضل بيه كان معانا من حوالي 17 او 18 سنه، كان في سورنتو في ايطالي، وكان الورك شوب الاساسي فيه كان على ديجا اوستيوتومي.
ان شاء الله.
هي طبعا دي باين لحضرتك مدى الاهميه بتاع ديجا اوستيوتومي. طبعا اتس ا فيري امبورتنت.
مظبوط يا دكتور محمد.
فاكر يا استاذنا؟
لا، وكان في كمان لو تفتكروا انا عندي مازال كان في تقول مثلا ايه هاند اوت كان ممتاز جدا في كل التايبس بتاع الاوستيوتومي
بالظبط.
موجود عندي لسه فعلا.
ربنا يدي لحضرتك الصحه يا فندم.
لا موجود فعلا صح.
كان من حوالي 18 سنه يا فندم.
مظبوط. تمام. وعندي الصور بتاعتنا احنا والدكتور احمد معانا، احمد علام.
ربنا يبارك في سيادتك يا فندم.
الله يبارك فيك. ولا كان مؤتمر رائع. ولو تفتكر حضرتك برضو كان اول مره ينزل فيها الايت بليت نفسه ستيفنسون كان موجود نفسه وعمل الورك شوب بتاعه.
ان شاء الله. وحشتنا يا دكتور محمد.
الله يخليك دكتور حبيبي. الله يخليك يا حبيبي. سعدة بالمحاضرة
يعني
بتاعتك الجميلة.
احنا يعني مش عارفين نقول لحضرتك الا جزاك الله خيرا يا دكتور وليد. والله
جزاك الله خير.
يعني ربنا يبارك في حضرتك. دايما محاضرات حضرتك ممتعة. اي حاجة حضرتك تعملها ممتعة، سواء كان محاضرات ورك شوبس اي حاجة. الحمد لله يعني فيها كم من الاستفادة يعني نسأل الله سبحانه وتعالى ان يجعله في ميزان حسناتك يا دكتور وليد.
امين يا رب. I hope ان احنا
رغم اننا مش محترفين بيدياتريك يعني.
لا ازاي ده حضراتكم
انما
اساتذتنا.
من باب العظام يعني. دكتور محمد
هو
فكرنا الميتنج بتاع الايبوس، فكان فعلا كان في فعلا حاجتين جداد في وقتها، وكان حاجتين فيهم اهتمام فعلا يعني.
هو يعني for بس the new staff or young fellows أهم حاجة في البيدياتريك is to be careful. Just be meticulous and be careful. Do the right thing. These are the cases ما ينفعش فيها استعجال. كل ما تدي more efforts to the patient, you get better outcomes. Over time, you feel like, oh, I'm still doing DDH in 2 hours or 3 hours or 4 hours. It's okay as long as you're doing the right thing. And don't skip a step. You say, oh, أنا عايز أخلص بدري النهاردة. أنا عايز. Never. Imagine this is your kid and you want to do a good job. This is the most important thing in pediatrics. It's easy to describe the techniques. It's easy to go through it. The other thing is the right indication. It's good to have a good protocol. في عندنا جروب في المنصورة في التأمين الصحي في المنصورة في صندوق دكتور خالد ودكتور إيهاب عثمان. بدأنا بروتوكول من سنة 2012 على الدي دي اتش، ماشيين على الديجا. they're doing amazing. خلاص once you focus on one technique. وانا صغير كنت اقعد انا عايز اعمل سولتر النهارده، بكره هعمل بيمبرتون، بعده هعمل ديجا. كل تفكيري ان انا عايز اجرب كل التكنيكس. بس think about the patient. Think what will benefit the patient. Since 2012, they have amazing results and less AVN, less growth issues. Because they focus. There's nothing new they added. But one system, make one system that fits and you'll be fine. We introduced Morsher osteotomy in Mansoura التأمين الصحي. They did way better than what I'm doing. درجة عاملين Morsher في osteogenesis imperfecta and the volume موجود في مصر. بس we need شوية system، شوية نظام and بروتوكول موحد نمشي عليه. حتى في الفولو اب، حتى في when we remove the cast, discuss, think. I'm very happy today with the questions. It means the people are working and thinking for the better care for their patient. And you might find some of what I'm saying today is only related to my practice. And because this is what I feel, I'm doing the best for my patient. But you might talk to someone else, says, no, I do different. That's fine. They might have better outcome with their way. But this is after I tried too many techniques, and I'm very happy with this. Thank you for questions.
I think we have 2 questions.
CP any place for sharp procedure in DDH? Shared. I don't know shared procedure, Dr. Ahmed. I only remember shared textbook. واحنا بنسجل الدكتوراه قالوا لنا لازم تقروا شارد، بس ما قريتش منه. بس yeah, it might be something I do, but I'm not matching the name.
I think we have no more questions.
I think we're good.
Yes. Thank you so much, Professor. Yeah, we have one question.
GMFCS versus bilateral DDH, what you do? GMFC versus bilateral. I don't know what's the GMFC. It's GMFCS level, you mean? So GMFCS level 5 by CP, is that my understanding? Bilateral DDH. Okay, so yes, so GMFCS level 5 bilateral DDH, I try to do them as soon as possible if they get migration index 40% or above. If they're younger than 5 years, and they're less than 40%, I do guided growth with a screw. Transfer of iliopsoas to the greater trochanter. Yes, Dr. Ahmed. I don't do it. I have seen it في الكتب في المذاكرة بس I've never done it. Selective rhizotomy is a good option. It's done by neurosurgery. In CP with DDH, no recumbent, non-ambulatory, I mean, do you think pelvic osteotomy to improve hygiene handling can be stable and beneficial? So yes. As I mentioned, the primary bone issue is the femur. So get the femur into the socket. This will prevent arthritis. Studies showing that arthritis and pain in the future is expected in more than 90%. They have horrible reaction to pain. We do have a team here is called the QALA team, the quality of life for end-stage salvage. It's horrible. It's a very horrible practice when they get into end-stage pain. Paralytic DDH is the same procedure. So it depends on what type of paralytic, but most of the neuromuscular primary bony issue comes from the femur, and usually the acetabulum is secondary because you're born normal or you're born with normal anatomy, and then over time the paralysis is the thing that causes secondary acetabular dysplasia. So most of them, I can't say all of them, but most of them, we start with the femur, usually get coxa valga, and even with the non-spastic CP, I do even more varus for them because you don't know what the pathology is, what's the muscle imbalance. All their muscles are hypotonic, and the hypotonic CP, I do more varus, and they might benefit from Sherrod procedure, but I have no experience with it. I used to read about it from textbook من قصر العيني دكتور بدير او دكتور كان في كتاب القرص دكتور
صالح بدير يا فندم.
صالح بدير دكتور صالح بدير. كنت اقرا all this muscle transfer and اساتذتنا طبعا اللي عملوا حالات كتير للبوليو. before the polio كان في كل الحالات السوتر والشارد والياونت these old techniques that people don't do anymore. Although I believe we missed this chance and opportunity to learn these techniques because they were amazing and studying biomechanics and studying all these things. عشان كده اتعمل معهد شلل الأطفال في إمبابة, and until now they have amazing professors understanding the pediatric orthopedics more than anyone else.
I think we come to the end, Professor Walid. Thank you so much, and hoping to see you again and again and again.
Thanks so much, Dr. Muhammad, and it's always my pleasure.
It's an honor for us, sir. Thank you so much, sir.
Thank you.
جزاك الله خير يا فندم.
نشوفك على خير ان شاء الله حبيبي.
نشوفك على خير دكتور محمد. السلام
واحنا
عليكم.
بنستاذن حضراتكم وعليكم السلام طبعا كده. جزاكم الله كل خير يا فندم. احنا هنعرض مرة تانية التسجيل بتاع الدكتور جمال حسني الورك شوب اوف external fixation in proximal femoral fractures. كان فيه some technical problems لأي حد حب يشوفه, لأن هو في العديد من الزملاء طلبوا إنه يعاد تاني. دكتور مايكل.
Yes, doctor, one second.
Can we prepare it, please, to be replayed?
Today we are going to discuss the external fixation of the proximal femur, the tips and tricks. Why external fixation is not popular in proximal femoral fractures? Because of the stability. They always talk about the frames, which are quite unstable. Also, when we see the cases, you can have reduction, unstable reduction. Also, they always talk about standard external fixation. There is no standard external fixation. So I think the companies and some people, they design a frame and they want to fix all the fractures with this frame. And this is not applicable. And I will show you how to fix the proximal fractures. And we put the frame last, not first. So our technique is not frame first technique, because the problem comes if you apply the frame first. What are the indications of external fixation proximal femur? We can use it in proximal fractures, in open fractures, osteoporotic fractures, firearm injuries, infected fractures, infected non-union, and these are examples. You can use it not only as a temporary fixator, but you can use it as a definitive fixator. Like this case of trochanteric and subtrochanteric fracture. And the other case, we have a fractured trochanteric fracture after fixation with external fixator. Also, we can use the closed reduction techniques in fractures. I'm going to explain them during the workshop by putting the wires, doing pulling or moving the fragments like this case. And this is an example of the closed reduction technique of this method using serrated wires, half pins in different directions. Also in infected fractures, if you have failure of internal fixation, like this case, you have failure of DCS, you can apply external fixator in the direction of the neck. Infected non-union, same. The methods of fixation of the proximal femur. Wire or half pin application first. We put wires or half pins first. The methods of fixation, number one, serrated wires, Schanz pins, cannulated Schanz pins, Elizarov wires, joint bridging. And these are the example of the serrated wires. We push the serrated wires in the direction of the neck till they hold the subchondral bone. Multiple wires, 2, 3, or 4 millimeters. And here also the same method, 2 Schanz screws. You can use Schanz pins in this way in the direction of DCS. And this is an example, Schanz pins. You don't have to have them parallel, because this patient had external fixator before. And this is another method of fixation by half pins. This is a cannulated Schanz pin. You can put a wire in the direction of the head and neck, and then you put cannulated wire. And also you can have Elizarov wires from the front to posterior in severe osteoporosis. You can palpate the anterior supiliac spine, and remember that the vessels lies 2 centimeters medial to the anterior supiliac spines. So you go lateral and put your wires from anterior to posterior and take care of the sciatic nerve also in severe osteoporosis. Bridging fixator, you can do crossover. Like this patient, we have only 1 half pins in the direction of the neck, but this is not enough. So we did supraacetabular fixation, and we are going to discuss the supraacetabular fixation. Also, we can use the closed reduction techniques. You can do the closed reduction techniques. You don't need open reduction. So in each case, they say that you do open reduction, minimally invasive techniques. No, we don't need to do reduction because you can do closed reduction techniques. And this is an example, trochanteric fracture over the proximal half pin 1 week after removal of the dislocated infected total knee prosthesis and debridement and temporary external fixator, but the patient had this trochanteric, subtrochanteric fractures. And severe osteoporosis and infection, and the patient is very fat. So remember that you can have the cantilever effect if you apply only half pins. So we have to use the subchondral bone for fixation. So we use the multiple threaded wires technique. And this is how to apply them under image intensifier. And this is the half pin. As you see here, we use multiple threaded wires in the direction of the neck and traction to close the gap. Then more wires and half pins in different directions to increase the stability, like this patient. And this is the picture after application of the frame. So we don't talk about the frame. You can use any frame you want. We talk about the fixation and the reduction. And this is the opposite to exactly what's going on in the literature. They always talk about the frame. We don't talk about the frame. We talk about the method of closed reduction. We talk about the methods of fixation. And this is with follow-up, as you see the follow-up, complete union of the trochanteric fracture. So in conclusion, Our technique is called frame loss technique. That means we apply the half pins, the wires, and finally we put the frame in the direction we want. And the closed reduction of fracture. It's a very important principle. If we talk about application of external fixation of the proximal femur, because we don't want to do open reduction, we want closed treatment. Now we finish the presentation, and we go now to the sawbone to show you how to apply it in the proximal femoral fractures in the sawbones. Thank you. Good afternoon, dear colleagues. Today I'm going to discuss how to fix the proximal femur by external fixation. The problem with fixation of the proximal femur, when you read the English literature, they always speak about the frame and how to have a fixed frame for each case. And this is the real problem. Because if you have a fixed frame, it's very difficult to fix the proximal femur. Today I'm going to discuss how to fix it in the opposite way. That means frame loss. We apply the frame as the last step of the operation because the frame is not that important. What's more important, how to fix the proximal femur, whether you have fractured neck femur, trochanteric fracture, subtrochanteric fracture, or you have non-union, infected non-union, malunion of the proximal femur, you can apply these principles in all these indications. I'm going to discuss 5 methods of. It's not one method like they discussed you, that you have to have 2 half pins above and 2 half pins below in a fixed fixator or something like this. This is not true. This is not practical. I'm going to tell you the tips and tricks of the fixation of the proximal femur using 5 methods. The first method is the serrated wire method. You can use serrated wire, 2, 3, or 4 millimeters wire. We have serrations for about 1 centimeter near the tip of the wire. And this is the first method. And usually when you put the wires, we put them in the direction of the neck. You see, this is the direction of the neck. We can put 2, 3, 4, 5, 6 wires. And you can put them in the fractured neck femur, and after you put them, you pull the proximal segment and induce the reduction. The same you can do it for trochanteric fracture. The second method is using the half pins, like this one, solid half pins. And the solid half pins, you can use them in the direction of the head and neck, again, like you put the DHS or something like this. The third method is the use cannulated half pins. You can put a wire first under image intensifier, and you check it by the image in the anteroposterior and frog position, the lateral position, and then you apply the half pin in the same direction. The fourth method, you can use half pin in this vertical, from the trochanter that way, like DCS. And you can use any combination together. So you can use serrated wires, half pins that direction, another pin this direction, and so on. The fifth method, sometimes you cannot have enough fixation on the proximal femur. You apply supraacetabular half pins. So we have 5 methods of fixation of the proximal femur. Then you apply the frame. You can apply Elizard frame, you can apply any type of frames after you do the reductions. Which type of tables you use? You use a translucent table, but you don't need to have a traction table. You can use a traction table, but usually I don't need a traction table to do it. The first step is the first method using the serrated wires, like this one. I will show you how to use it. This is the thin one. And you put it here in the subtrochanteric area. And you take the direction of the neck. You see, this is the direction of it. Put another one. This is one of them. When do you stop? I usually stop at the subchondral bone. Remember, some patients with trochanteric fractures or neck fracture, neck femur, they have very osteoporotic bone. So you have to go till you catch with the serrations like this one. You see, this is the second one. You take the anteversion. You can use image intensifier. This is the second one. Third one. This is 2 millimeters wires. We use the third one, and you use the third. You need stability, so you need more and more stability. Again, this is, you see the third one. We can go below this, and you change the direction, and this is. So this is the third one. Now we are going to use 4 millimeters wire with the serrations like this one, and we go from, again, yes. So we have 1, 2, 3, 4 points of fixation. This can be enough. In many cases, if you have a neck femur, if you have, put a wire here. So this is the first method. The first method is to apply serrated wire technique, where the serrations stop in the subchondral bone. Now you can pull to induce compression. The second method is to use the half pins, the 6 millimeter half pin. How to use the half pins? Again, under image intensifier, you can put wire, and with the 6 millimeters half pin, you can put the half pin in the direction of the head and neck. Again, yes, this is the first one. And we can use a second one. So you can have 2 half pins in the direction of the neck. You can have more if you want to. The neck is wide, you can have more. So this is the second one. So the second method is to apply 2 Schanze screws. The third method, you can put one of these wires like ditches, then you introduce the cannulated half pin. The fourth method, we are going to use the Schanze screws or the half pins in the direction of the DCS, like this. So it's about 90 degrees. This. Why we use it that way? Because sometimes you need to have more proximal fixation, because there is a problem with this area, because the patient has, you have removed external fixator before, so the patient has many holes here. So this area is very difficult, and perhaps you are going to have subtrochanteric fracture. So you need to have very proximal fixation. So you can apply it in that direction. How to apply the half pin in that direction? First, you introduce a wire in front of the bone, as you feel it, just in front of the bone, under the image intensifier. And now it's in front of the bone. We leave it just like this. This is in front of the bone. Give me now with the drill bit. We go the same direction like the drill bit in the middle of the trochanter, like this one. We'll go through the middle of the trochanter, and we go with the drill bit in the same direction. And this way, you can change the angle of anteversion. We knew the angle of anteversion from this wire, the superficial wire. So it's about 15 degrees Yes, so you can move it up and down to correct the anteversion. Then you go with the drill bit. You see, you went through the bone. Then we remove it. Then manually you introduce your Schanze screw. Take care that sometimes it's a very soft bone. So it's better to avoid too much heat. So we go manually, bit by bit. You see, it's okay. See the whole length. Till we finish the serrations. Yes, we finished the serrations. Take care, you need long serrations. That means you need 6 centimeters, 6.5 centimeters, 7 centimeters, so you have a big length. It's longer than normal. So you need to have half pins with longer serrations. It's not just 3 or 4 or 5. If you manage to fix this in that direction, 90 degrees direction, or the direction of the neck, you can use both. In some cases, we used both of them. In some cases, we can use wires and this half pin and chin. And I will show you on the slides. You can make any mixture. As I've told you, you can have very good fixation of the proximal femur, because the people, they always complain that it's very difficult to fix by external fixation the proximal femur, and they warn you from fixing the proximal femur if you have osteoporosis. This is not true. For every problem, you need a solution. Now, this is the fourth. I've told you the 4 methods of fixation: using the serrated wires till you reach the subchondral bone, using half pins in the direction of the neck, using cannulated half pins, using half pins in the direction of DCS, like this one, any combination. The 5th method, if you have rare problem of the proximal femur, you can add supraacetabular fixation. And I will show you how to fix the supraacetabular area. The supraacetabular area is very important. It's good, it's hard, it's easy to apply, and you just have an image, and you can put your half pins in this direction. So you can augment the fixation of the proximal femur by adding supraacetabular half pins. And I will show you an example how to use the supraacetabular half pins. This is the acetabulum. This is the acetabulum. Give me a wire. Feed if you are. Again, the patient is lying down, supine position, and you see this is the supraacetabular area, and under image intensifier, you just push your wire. To give you an idea about the direction of the supraacetabular area. And after you put your wires, you can use the half pins, give me the half pins, the Schanze screws, and you can, in the same direction, put, you see, you stop before, just at the second cortex. You see here, this is the second cortex removed. You can put 2 or 3 half pins, and this is very good fixation also if you have a fractured acetabulum or a fractured pelvis. And you can put another wire, you see here. Again, yes, okay, that's enough. So this is the 5th method of fixation. So we have 5 methods of fixation. This is the real operation, not the fixator. The problem comes, the people talk about the fixator, and have to, it's not a standard fixator. After you finish application of the wires and half pin, you design the fixator according to this shape. Coming to the distal femur, you can use 2 half pins, show me this, 3 half pins or whatever, vertical to the bone. another half pin. So this is the distal femur, and this is the proximal femur. So you can use two half pins in two different directions and so on. You see, removed. For each Schanze screw, you have to do the drill bit first. Show me the drill bit. And then when you use it, you can apply manually. This is the real operation. At last, we apply the fixator. Show me that. So we have arches, something like arches. You can use small arches, big arches, like this one. Like you see, this arch can be applied to this half pin. And you can apply Hartley Renko cube. You can, a bigger one, you can use Renko cubes if you want. Put more. But if you have this direction, what to do? Then you post mail, 3 holes or 4 holes, yes. You can use this post mail والقابض على الهاف pins. Post mail and the half pin fixation bolt, you can put it in any direction you want. So you can rotate it. The half pin fixation bolt, you can rotate it to fix it that direction. So you can change the direction anytime you want. This is for the proximal femur. For the distal femur, you can use another arch in the proximal femur, you see, and you can fix them together. Give me another arch. See. So if it is, you can put it that direction, and this is that direction, and put the links in between. Or in this direction and that direction, put it in between. You can put another arch in the proximal femur. So in conclusion, you can treat fracture neck femur, trochanteric fracture, subtrochanteric fracture, cases of malunion of the proximal femur, non-union of the proximal femur, infected non-union of the proximal femur. You can apply external fixator, and you can use the closed reduction techniques using the external fixator. You don't have to do any open reduction. It's all closed. You start the operation with the fixation of the fragments with 5 methods: serrated wire technique, half pins in the direction of the neck, cannulated half pins in the direction of the neck, half pins or Schanze screws in the direction of the DCS, or you can apply also supraacetabular fixation. Proximally, it's easy and there's no problem. After you finish, you apply the frame, any frame you want. I'm not going to talk about circular fixator or unilateral fixator or Ilizarov or whatever you want, any type of fixator you want. Thank you.
شكرا جزيلا دكتور مايكل. الحمد لله وصلنا لنهاية الويبينار بعد 3 أشهر من تجهيز والاستعداد المكثف. 26 ساعة من المحاضرات على مدار جمعتين، 75 سبيكرز من 9 دول، 2000 اتنديز من 35 دولة، 4 لايف ورك شوبس، لايف سيرجري with panel discussion. طبعا أنا أول حاجة بشكر يعني فريق شركة إيفا فارما، دكتور مينا ودكتور مايكل، اللي أنا سهرتهم وتعبتهم ويعني بذلوا معايا مجهود فوق الوصف. بشكر حضراتكم جميعا، ويعني إن شاء الله الكنز العلمي ده يكون available على اليوتيوب شانل الخاصة بجمعية جراحة العظام المصرية within 2 weeks إن شاء الله. يعني سامحوني لو في أي تقصير، نسأل الله سبحانه وتعالى إنه يتقبل منا اللي إحنا عملناه، وإن إحنا إن شاء الله يعني نقابل حضراتكم في ويبينارز تانية وفي جلسات تانية، وإن ينفع بينا وينفع باللي عملناه ده كل الزملاء، وإن شاء الله نراكم على خير. شكرا جزيلا، تصبحوا على ألف خير.